Good afternoon. My name is Emily Herzog, and I'm a program coordinator here at the University of Michigan School of Nursing. Thank you all for being here today for our Epic Pathways Leadership Series. Our talk today is titled Black Men's Health 40 Years After the Heckler Report, Where Do We Go From Here? Featuring Dr. Derek Griffith of the University of Pennsylvania. Dr. Jade Burns, assistant professor here at UMSN, will be moderating a Q&A following Dr. Griffith's presentation. So please feel welcome at any time to submit your questions using the Q&A feature in Zoom. We are recording today's session, as you know, but only the speakers' videos will be shared, recorded and shared. And we also stop recording as soon as we start the Q&A. So once Dr. Griffith's presentation is done, we stop recording. We've also enabled automated captioning as well. Before I hand things off to Dr. Burns, I just want to invite you all to our final Epic Pathways Leadership Series event of the year. We're going to be welcoming Dr. Christina Nicolaitis of Portland State University on March 12th at 12 o'clock for her talk titled Neuroaffirmative Approaches to Providing Care to Autistic Adults. This event will be in collaboration with the Disability Justice at Michigan org, and Dr. Nicolaitis will be speaking on her expertise in caring for adults with autism, including her work as co-founder and co-director of the Academic Autism Spectrum Partnership in Research and Education, also known as ASPIRE. So I'm going to put the registration link in the chat quickly, and then I'm going to now hand it over to Dr. Burns, who will quickly introduce Dr. Griffith.
All right, thank you, Emily. Okay, we are honored to welcome Dr. Derek Griffith to the Health Equity Leadership Series today. Dr. Griffith is the Risa Lavizzo-Mourey Population Health and Health Equity University Professor at the University of Pennsylvania. At Penn, he is also a fellow and senior advisor on health equity and anti-racism for the Leonard Davis Institute of Health Economics. Outside of Penn, he serves as the chair of Global Action on Men's Health, a global men's health advocacy organization, and editor-in-chief of the International Journal of Men's Social and Community Health. Trained in psychology and public health, Dr. Griffith's research focuses on achieving racial, ethnic, and gender equity in health. He specializes in community-based interventions to promote Black men's health and well-being, and anti-racism interventions to mitigate and undo the effects of structural racism on health. And also, we are just so happy to have you, Dr. Griffith. I know personally, your work is just very meaningful, and I've used it quite a bit in my work with adolescents and young adults, specifically young men, and we're just so happy to have you here. So welcome, Dr. Griffith. You may take the floor. Thank you.
Thank you so much. Thank you, Dr. Burns, for such a warm welcome. Let me get myself organized here. Okay. All right. Well, again, let me say my thank yous and give greetings from the land of the world champion Philadelphia Eagles. Let me start there. As much as I still claim being a Detroit Lions fan, I do have to at least celebrate, the success of being here. Let me also take a moment of speaker privilege to acknowledge one of my, as a friend calls it, my friend-tours, Gary Harper, who really, from a professional standpoint, introduced me to public health as a doctoral student, even though he doesn't look old enough to have done this. He taught me as a doctoral student at DePaul University and taught us a class in health psychology. And actually that was really instrumental in shaping particularly a lot of the community-based side of what I do in this work. So it's truly a pleasure and honor to be here to speak, with you, for you as well. Okay. So let me figure out. Okay, there we go. So today what we're going to do is start by talking about the significance of the Heckler report. This is the 40th anniversary of the report, and talk about why it was such an important watershed moment for the work on health equity. And talk about a little bit what progress have we made since that time, and make the case that not only could we have made more progress had we focused on men's health in general, and ultimately men's health equity, but that going forward, that focusing on men's health, and I'll use the case of Black men's health to illustrate this point, that men's health should be one of the foci going forward. Let me say, from the beginning, no, I'm not saying we should not focus on women's health. No, I'm not saying that we should only focus on men's health. No, we should not take resources, attention, anything away from women's health. But we can do both, focus on women's health, focus on LGBTQI plus populations and their health, as well as focusing on men's health in this particular moment in time. And I think all of those are really critical and important. What will be interesting to start with as we think about the task of the task force, again, in 1985. I can only imagine the fashion at the moment. I'm sorry, but only imagine sort of the moment in time that they were in, and some of the work that was going on and the importance of the moment. But if you also think about the response to this national paradox that they were describing, the improvement in health status, the focus on what became the dual focus of Healthy People the Healthy People program, that area really has anchored in two things. Obviously, promoting the health and well-being of the overall population, but this was one of the first times that a federal agency, a federal effort had acknowledged that there are these systematic and significant health inequities among racial and ethnic groups in the United States. And again, that we still sort of struggle with that today, and we still grapple with how do we improve the health of the overall population, yet how do we close gaps? But this was the first time that we actually had acknowledged this at that level. One of the other interesting anchoring parts of this was one of the first time, and frankly, one of the few times, at least that I'm aware of, where across the Department of Health and Human Services, so across NIH, across CDC, across these organizations, these large entities within the federal government, that they actually collaborated to come up with a strategy and an effort to address these issues and to think about what a comprehensive and coordinated strategy would be to understand and address these disparities in health status, and particularly focusing on the marginalized communities in the United States. So Black, Hispanics, Asian Pacific Islanders, and Native Americans were the populations of focus at that particular point in time. One of the interesting points of this, they focused on these 6 causes of death that accounted for 80% of the gap that they were interested in. So they focused on a statistic what is called excess mortality, which is interesting and important, but it's highlighting that if you compare to the white American group and the health and well-being of white Americans, then 80% of the difference between white Americans and the other collection of minoritized groups in the United States, it was accounted for by these 6 issues. I make that point and highlight that because it highlights a few things that we should, again, in hindsight, potentially reconsider. What is the benefit to comparing to the white population when we're talking about these issues and we're talking about overall things like life expectancy, premature mortality, and so forth? White Americans are rarely, if ever, the best group. So there was an opportunity, if our goal is to truly improve the overall health of the US population, that we could actually focus on what is, the best group, and then actually compare to that, which would include setting metrics, goals, and aspirations for how we would improve the health of white Americans as well. It also was not necessarily the leading cause of death, but it was the leading causes of the gap between white Americans and other racialized groups in the United States. And so again, if we were to focus on the leading causes of death versus what explained the gap between white Americans and the rest of the Americans in terms of this racial comparison, then we may have had different progress, or would have potentially had different outcomes. But it's not to criticize what they did, because this was an important and landmark moment, only to say that as we think about going forward, these are the kinds of decisions that we have to be really clear about, and think about what are our ultimate goals that we're trying to actually achieve, and perhaps consider making different decisions, even if ultimately we decide to make the same ones. So one of the big picture issues that I want to sort of circle back to and sort of anchor my remarks in today are this quote from Henry David Thoreau, that it's not what you look at that matters, it's what you see. And part of the argument that I'm making for men's health in general and Black men's health is that what I'm going to show you are data that we basically always look at. I'm showing you statistics that are not anything fancy, that are not anything unique, but it's just looking at them differently, but looking at the same stats we always have, but it's asking different questions based on what we're actually constantly looking at. And so it's being more precise and looking at it, potentially in a slightly different way. One of the key ways that I propose looking at these data is through the lens of intersectionality. And, intersectionality, as many of you know, has been something that particularly Black women scholars have been studying, using, applying, whether it was labeled such for more than 150, 170 years. And certainly got a lot of attention in the last several decades. But it's really the idea that, and it came out of particularly legal scholarship that identified that they couldn't identify, in this case, the employment needs and issues and rights of Black women by only looking at women as a group, because white women were being employed in that particular sector, and they couldn't just look at race because Black men were being employed in that particular sector. So they needed to think about what was the intersection. It was only when you actually looked at the simultaneous combination of looking at race and gender in this case, that they were able to identify where there were gaps, and it was at that intersection that we saw it. And so one of the key questions from one of the key scholars in that space, Kimberly Crenshaw, certainly she's not the only one, but her work in particular, I find particularly useful because of the systematic way that she approaches intersectionality. She asked the question, when you look at an issue that's traditionally regarded as gender, she asked the question, where is race, or where's the racism in this? The reason that she asked, where's the racism in this, and not just the race, and not just where's race in this, is because she's identifying what's the process that's behind explaining the patterns that you actually see, not what is the measure or the proxy or the demographic variable that you're actually looking at that tells you what it is. So this is identifying what's the mechanism, not just what's the marker, if that makes sense. And so the second part of the way I flip this a little bit is when we're looking at the issues of racial inequities, that we're really then asking also, where's the gender in this? And the reason I'm going to ask that, you'll see, is that there are significant amounts of sex and gender differences that we see, that we can talk about whether or not we would call those disparities or not, and whether or not that fits the definition. But nonetheless, it identifies a population in need of attention that we need to pay attention to. Again, if our goal is to improve the health of the overall population, we have to do something with the groups that tend to be doing worse. So this is what I did to try to illustrate some of these points is, and my class, if they're watching, will recognize some of these slides, that one of the things I was highlighting here is what's the progress that we've made for certain groups, or as it relates to closing certain gaps. When we talk about disparities and inequities, one of the major focus that we have is to close those gaps, independent of how much we're actually often trying to improve the health of those populations. Those are actually two separate goals that end up sometimes getting conflated. But if you're being very literal and narrow, that the goal of equity and equities is often to, depending on how it's defined, it does include those two parts, that you're trying to improve the health of the populations, but also improve the health of the group that's doing worse at a faster rate than that of the group that's doing better, while improving the health of both simultaneously. So what we've seen here is that there was not major progress in that 40-year period that we saw of the data from 1980 to 2021, that we really hadn't seen significant progress at all in closing the racial gap among men or among males in those groups. And I'm going to go back and forth between sex categories and gender because most of our data, we don't have data on gender in large part at a national level. That's one of the things that we need to do differently in the next 40 years, is actually capture data on gender. But we also need to think about what are the implications of that, or not having that data, by just looking at biological sex. And as important as biological sex is as a determinant of health, it pales in comparison, if we're really ultimately trying to improve the health of the population, to being able to look at the environmental influences, the environmental effects that are really operating through gender more so than they are operating through just looking at the biological factors of what people are born with. What you also see is, if you're looking at between Black males and Black females, that we did make a bit of progress in this space, a bit more than we did before. But when you also break these out a bit more and you look at for whom did we actually make the most progress. So this is looking at Black-white differences within sex groups. So the orange bar is, basically showing that we didn't make that much progress in looking at males, 6.9 to 7. We did make a decent amount of progress in actually closing the gap between Black females and white females of over a year. And so the point here is that if you're looking at how we were actually able to progress and the change and the kinds of changes that were made over time, that we made far more progress in the rates and in addressing issues as it related to Black women and women's health than we have necessarily for improving the health of men. It also means that most of the progress that we've seen when we look at racial gaps and we basically collapse racial and ethnic groups, we collapse across gender groups and just look at it as one factor and not really break it out by sex or gender, that most of the progress that we've seen is really driven by the progress that we've seen in improving the health of women, in this case, Black women. So it suggests that we need to pay attention to these nuances, pay attention to these differences, pay attention to the ways that our society is differentially affecting our particular population groups. Again, I'm certainly not suggesting that we need to do less for Black women's health. We actually need to do more, particularly in more key areas that are affecting their overall rates of everything from maternal mortality to, cancer, particularly heart disease, cancers, and so forth. So all those critical leading causes of death. One of the interesting things, again, looking at the data from 40 years ago, is the 10 leading causes of death were basically the same for males and females at that particular, for Black males and females at that time. And again, just highlighting here, the 6 leading, the ones that the Heckler report chose to focus on: heart disease, cancer, unintentional injuries, homicide, infant mortality, and diabetes. And I think they collapsed chronic liver disease and cirrhosis with diabetes, I believe. But basically, those are the issues. And the point is that we are skipping things like cerebrovascular disease, pneumonia, and influenza, and so forth, where they are leading causes of death, but they didn't choose the 6 leading, is what my point was. What's also important in just highlighting, not only were the differences in the gaps that we saw, but we also saw differences in the rates that we're actually trying to close. So what I'm saying is, if you think about again, these leading causes of death, we already knew that within these particular health issues that we see that there are sex differences in the key 5 of the 6 key priority areas. So had they chosen to actually say, oh, 5 of these, 6 key areas that explain the racial difference between, in this case, Black Americans and white Americans are actually heavily gendered, meaning that they have far higher rates in men than they do in women. We need to consider that. We need to include that, particularly as you see the major gaps in the top 3, unintentional injuries, cancer, and heart disease. If we had considered those factors in there, we may have made even more progress than before. Now, one of the things that's really fascinating about focusing on men's health is this interesting paradox that we don't tend to really grapple with. The only thing to notice here is, so whatever this is. So I only had like 8 crayons when I was little. So, my crayon box didn't include all these kind of things. So like in my head, I know that's a shade of red or rust or the darker color, let's go with that, is white Americans. The yellowish orange, I guess we'll call it orange today, color, that is Black Americans. What you see is that within these groups, what you're noticing is that consistently we've had, again, not surprisingly, both sex and racial and ethnic differences in income that we needed to also consider as it relates to these things. What I'm not saying well, and getting to the point is, one of the things that makes men's health an interesting paradox is it's one of the few areas where the group that is advantaged in economics and political power and influence and so forth is not the group that actually has better health outcomes. We know that in most areas, and we can talk about other areas where men fare worse than women, but in most key areas of life and sectors of our society, women are disadvantaged as it relates to men. And yet women have better health outcomes when it particularly comes to these leading causes of death and major health issues. That pattern doesn't hold for many other differences that I'm aware of in the epidemiology of our larger fields. When you think of racial and ethnic differences, when you think of even socioeconomic differences, invariably we know that the group that is more structurally advantaged or is doing better actually has better health outcomes. Men's health is one of the few areas where having more advantage doesn't necessarily lead to having better health outcomes. So that for me is one of the things, not just my self-interest, but one of the things that makes it a particularly fascinating and important problem that we need to address, because it suggests that some of the models that we have for understanding things like health inequities may not fully apply. And using a model that would consider how these factors make the determinants of health, how the intersection of race and gender make the determinants fundamentally different, qualitatively different for, again, Black men versus Black women, for white men versus white women. And as you start to do the good social psychology 2x2, Black, white, male, female sort of table, that those patterns don't hold just based on, the being able to control for one variable at a time. And so it does mean that our science needs to really advance to better understand how these patterns actually play out. And we need to better understand how these factors are not necessarily additive, but actually maybe qualitatively different depending on who we're talking about and what moment of time that we're in. My students know that this is one of my favorite slides all time. If you've ever taken a class with me, I'm sure I've shown this particular graph. And it shows a couple of key points that I think are just critical and important as we think about explaining these issues and figuring out, therefore, how we need to address them. Obviously, it highlights and reinforces the idea that if life expectancy is a proxy of overall health, that everybody in America is living longer lives, is therefore being healthier. But we had from the beginning in 1900 of at least these data, so this is a 120-year period, that 1900 we basically always we had racial inequities in health, and we've had them basically throughout this whole period. Yes, they closed a little bit, but we still had these persistent disparities. What you see though is actually when you look at the dark blue versus the red, and then the lighter blue, medium blue, Honolulu blue versus purple, that the sex gap within a racial group was very small and has actually grown over this period of time. Let me show this in a different way. So this is looking at sex differences independent of race and ethnicity. And you see that basically we've always had these sex differences when we look overall, and they've actually grown over this period of time. When you look at racial differences between Black males and white males, so within males, what are the racial differences that you see? That those have actually decreased. We've actually made progress in addressing the racial issues, racial differences, and decreasing the racial differences among males during that period. The one that usually is, complicating and that we don't have good understanding of is this one. That we started with a relatively small difference in life expectancy between Black females and Black males in 1900. It went from 1 year then to more than 8 years in 2021. Why there would be such an eightfold difference over this period of time when we know, when it's not clear why, let me just say it that way. Why would both race and gender and the intersection of the two matter so much as it relates to explaining and helping us to understand or seeing the differences that we're seeing in these patterns in this overall metric of poor health, or of health, sorry. And what it also reminds us is that, again, while biology, sex matters, the reason that I'm arguing that we focus potentially more on gender and some of the other social factors, people's social experience and so forth, is because biology didn't change so dramatically in this 120-year period. There's nothing about our genetic makeup, experience and so forth, constitution that was different in 1900 that we would have expected to change so dramatically that would help explain these patterns either by race and certainly not by sex. And so it suggests that there is something about the environmental exposure, experience, context that is changing that we need to recognize that it's intentionally or unintentionally, largely unintentionally, I would assume, that most of the progress, technology, advances, things like sanitation, all kinds of other things, working hours, have not affected population groups the same. And the more that we're able to take those things into account and understand those determinants and how they are, again, the ways that race and sex are intersecting the way and influencing the way that we understand these issues, that our solutions need to reflect that more nuanced understanding if we're going to be successful in continuing to improve the health of everyone while we continue to close these gaps. So this is just to highlight that this pattern also persisted during the COVID period, and to also make sort of a point just as a professor. So one of the things that I often note is when the scales, so for those who take epi, do epi and so forth, one of the things you typically don't want to do is have your graphs, particularly figures and tables that are sitting next to each other, to have different scales. But interestingly, it is not uncommon in the context of comparing sex groups that we actually do have different scales. And that can misrepresent what we're actually seeing. So we have females on the left, males on the right. And if you were to look at it visually and not pay attention to the scale at the bottom, that you would actually think that the rates were roughly the same. But you don't realize until you actually look more closely that the scale, the top number for women is 4. The change in life expectancy, the decrease in life expectancy is actually 4, versus the decrease in life expectancy for males was 5. And so there was quite a significant difference if you would actually put them on the same scale between the changes in life expectancy, the adverse effects of COVID and that COVID period on males and females. Overall, and specifically within racial and ethnic groups. And then you also see that essentially the US is at the bottom, with the exception of Spain being right there with us, particularly as it relates to females. So there's something in how we're doing what we're doing. There's something in, the way that we responded to the pandemic that had implications for why we had so much more loss of life, so much more a decrease in life expectancy than our high income peers. And so we have to look at this both, again, how it affected our overall approach to how we think about what this means for what we do going forward. That the one size fits all approach that we tried during this period and other approaches that we tried that didn't take these things into account, you see that for both males and females, that Blacks and Hispanics had much higher rates of being affected and impacted as a community by the pandemic and by these other issues than we actually have really paid attention to. And one of the things that I often get, I just want to note, is that often some of the times I hear, well, all health historically has been men's health. So what are you actually talking about? Why are we talking about men's health? We've always sort of prioritized focus on men's health. And, it's taken forever for us to even get, any kind of infrastructure traction as it relates to the health of women. I certainly agree that that is the case. What my friendly amendment is that we have tended to focus on male health and not men's health. The distinction I'm making is we've used male bodies as the biological norm, the standard, the anchor on which we base everything from, metrics of success, metrics of health, how do we dose medications, all kinds of other things. We use men mostly as the ones who have been studied in various drug trials and other health issues, looking to see if different ways that we've improved, that we intervene to improve health have been effective, had largely been based by studying males, and that has differentially affected how been able to understand and address the needs of women. What it also has done, though, is not really given us the ability to understand effectively how we need to understand the health of men, and particularly understand their social lives, their social experience, their social exposure, how we understand how males are affected by the larger gender systems and the way it intersects with other things like race, ethnicity, sexual identity, orientation, all these other factors, not to mention place and so forth. So that our approach has not served men well. It hasn't served women well, and I think we can do better if we were to actually use sex disaggregated data to inform policy. If we actually were to use a more gender responsive approach to these issues, where we consider gender, but consider and define gender as being something that also includes males and men, not just that gender is synonymous with women and women's health. One of the reasons that I think we focus on men and men's health, or that we haven't put as much attention to men and men's health, and this is one of my favorite ads all time, and it is a real ad from the Agency for Healthcare Research and Quality. They actually had a whole series of these. This is just one of my favorites. That explains sort of the underlying assumption to why men have or the implied sort of way that we understand why men tend to have poor health than women. It's that we locate the nature of the problem of men's health in men's heads, essentially, and say that it's basically because of the way men conceptualize whether or not they're going to seek help, go to the doctor, all of those kinds of things, that it's within the ways that men approach these issues, the psychology of men, the way that they approach attitudes towards what it means to be a man, attitudes towards health, that if we just fix men in those ways, then we will solve all these issues. We'll close these 5 to 6 year gaps in life expectancy and related issues. And we don't need to do anything like create courses in men's health. We don't need to have an office of men's health. We don't need to create infrastructure in men's health. We just need to get men to change themselves. And the challenge is that it absolves us from having to take accountability at higher levels, to create policy, educational interventions, training, education, for clinicians, for nurses, for other professionals to better serve the needs of folks who fit under this umbrella and group. And so that is the challenge that I have with this kind of approach. Richard Reeves has been one of the leaders in this space of thinking about how we need to approach this differently, and noted in his book of Boys and Men that the problem of boys and men is structural in nature, as I've sort of been alluding to, but it's rarely treated as such. It's treated as much more of an individual problem. And this is just a more articulate way of saying and more pithy way of saying what I just said a second ago, that we need to think about men in their structural context, not just men as individuals who are thinking about sort of their psychological lives and so forth. There are areas where men are falling behind, and where men are not necessarily at this moment in time structurally advantaged. Again, we can quibble about it, but there's more data in his book that can help explain these differences. But when it comes to differences in educational attainment, both in primary and secondary school as well as in college, we're seeing that boys tend to fare worse in those spaces than girls. We know that when it comes to labor market, both in terms of the ways that the unemployment rates and other kinds of factors, that men are faring particularly worse in those spaces. And we also know that men's roles in families have been less well defined as we've made progress in disentangling the provider role from males. And that has been an important advance to create gender equity, to promote gender equity. But it's also, for a lot of men, left them not knowing what their role in a family is. And so men have struggled collectively to redefine what it means to be a man if that is not sort of a central part of their role. Now, I'm not in any way promoting going back to the 1950s or any kind of previous time or place where women are structurally disadvantaged, particularly in families, or anything else that would promote further inequities between men and women. What I am saying is that there's something about the ways that we need to help men figure out how to live in the 21st century, how to be part of families, how to be part of communities, and how to change the way that they're being trained and educated, both personally as well as professionally, that needs to be updated, and that we need to consider those unique contexts as a way to improve the health and well-being of everyone in society, not just of men. When we think of some of the gaps, that these are global problems and not just ones in the US. I'm focusing on the US context for the sake of making this manageable within a particular time frame. These are 4 reports that I've done as part of my role, or I've not done. Global Action on Men's Health has commissioned, and we've had colleagues do a wonderful job of writing and editing that have highlighted the fact that in global policy documents, global organizations, WHO, transnational organizations, regional offices of WHO, that when you look at those documents and you look at the representation, how gender is operationally defined, how men are treated in those and characterized in those, and whether or not we actually have data that speaks to metrics for men in those contexts. When we've looked at cancer, mental health, sexual and reproductive health, and men's representation in primary care, we've essentially seen this consistent pattern that men, particularly when they do worse, are not necessarily focused on, and there aren't metrics, there aren't recommendations for improving men's health when men are doing worse. And that in most cases, we don't use sex disaggregated data to inform policy and so forth. And again, that is not something that just hurts men, that also hurts women and our ability to focus on what are the needs of women in these contexts, in these spaces, and in these particular health issues. Since for all of these, I mean, it's very obvious to see that for each of these key areas, and of course many others, the needs of women would be fundamentally different than that of men in these particular spaces. And so being able to have policy inform how we would approach women's health would be really critical as we think about the ways that we would go forward. As I start to close, one of the things that we need to pay attention to is, again, there's no infrastructure for addressing men's health. Most entities within the federal government have an Office of Women's Health. There are no such offices of men's health. When we look at metrics of things like healthy people, there are far fewer metrics that actually, we do have a lot of metrics for population groups. We have over 40 for children. We have about almost 25 to 30 for women and so forth. We have very few for men. The ones that are for men are not reflective of the leading cause of death for men. They actually, one is on prostate cancer, one is on family planning, and two is on sexually transmitted infections, which usually is looking at men as their vectors to women's health. So the point is, if we were actually trying to improve, again, the health of men in this particular context, we would need to map it more explicitly onto leading cause of death. Just as a concrete example of something that we could do differently as we go forward, again, this is another one of those, don't ever do this if you're a student, that these are looking at cancers and mortality rates from cancers among Black Americans, and males are on the right, females are on the left. You see clearly if you just look at the pictures that lung cancer is the leading cause of death for both males and females. What you also see, though, is the scale is basically a 3-to-1 difference, and that's not something that is highlighted in this image. But for the male scale to be, up to 140, and the female to be 45, yet they're presented as though they're on the same scale, is problematic in the way that it creates the narratives that need to really be used to inform policy. The reason that becomes important is because something like tobacco, something like menthol cigarettes, if we were to actually consider and include the ways that we think about men and the ways that we think about the targeted marketing, not just to Black communities, but specifically to Black men, that we would have a different response. We would need to consider these issues since, again, lung cancer is the leading cause of cancer death for all Black Americans, and all Americans for that matter, that if you actually used a gendered approach and recognizing that tobacco use is disproportionately higher in men than in women, and again, when you intersect it with race, that those factors have a critical role in how we would understand and could address these issues, and the lack of policy attention that considers the ways that these issues and the targeted marketing were actually, again, at the intersection of race and gender, suggests that we have not had an optimal response to how we can address these issues. We already know that we've struggled to figure out how to address menthol cigarettes, and there's been a reluctance, to say it gently, to addressing those issues. But it is also to say at a higher level that these issues have consistently been a problem, and We need to, if we're really going to be serious about addressing lung cancer, that we do need to factor in the fact that it's men who have these higher rates of tobacco use, lung cancer, and menthol cigarette use specifically. So what we tried to do here, again, is to talk about the significance of the Heckler report and, again, anchor that as a foundation for thinking about, what is it about what happened 40 years ago that was such a landmark anchor to our ability to understand. It was the watershed moment for really recognizing what became our focus on collectively health disparities, health inequities, and health equity. And talk about some of the progress or lack of progress that we've made since that point, and then highlight that men's health could have been and should be potentially a major focus, and that just a gendered approach would be really critical, but a gendered approach that also considers the intersection of gender and other factors. I focused on race here. We need to focus on a variety of other factors as we go forward. I won't, in an effort to keep this short, won't try to name and illuminate all of them, but we need to think about, essentially be intentional and be explicit about why we're including what variables of looking at success and evaluation of programs and policies and what those are, what's the justification for choosing those, and how we approach those issues. So again, it's not a matter of what you're looking at, it's how you see it and what you see that is so critical for how we approach these issues. I will leave out the part of how I got in trouble for saying things like, I'm skipping past it. The idea that men are doing worse has been challenging for a lot of Americans. And I get it because of what we're talking about, that men are structurally advantaged, again, in most, if not every area. I said in my shorthand, and got in a lot of trouble for this, or became at least, well, I call it trouble, but I would also call it a good thing in that both from folks on the right and on the left, I was getting nasty messages basically saying, why are you focusing on men? From certain folks, and then why are you talking about stuff? Why aren't you? That basically it didn't matter. I was a unifying force that folks pretty much across the political spectrum were wondering, why am I talking about these issues? And then actually this morning there was an NPR story where I'm being quoted again. So, but this time hopefully I didn't say anything quite this inflammatory to some people's minds about structural advantage and so forth. But the fact that I'm highlighting this paradox is something that folks have had a really hard time with. And not just, it wasn't just about me. I don't want to make that about me, but it was funny that I was getting these, I'd never gotten that kind of messaging before in emails and other stuff. And it surprised actually, I'm sorry, you can't see well down here that there are 985 comments that they got from this article that was a random weekday that was talking about the crazy idea that men actually potentially have worse health outcomes than women. Males have worse health outcomes than females. That idea that basically is present in every data source, every data thing that we have, for some reason, when it got into the public 2 years ago, became like this big lightning rod sort of issue, at least for a hot second. And it surprised the editor and the author to the degree that she had to write up another piece a few days later to basically say she was surprised. It's startling how many people are offended by the idea that men are suffering. Others say that the longevity gap is simply due to biology and we should just accept it. It's actually not due to just biology. The biology plays a part. It's not the only thing or the major thing. But I think we can do more. And so I leave that to say that, again, we can do more, we can do better. Again, we can promote women's rights, equity, and so forth. I've never done this before. And we can promote those issues while we actually promote men's health. We don't have to choose, as Vivek Murthy said, between choosing the health of his son and his daughter, and we wouldn't accept making a choice between the health of either. I don't think we should have to, and I think we can do both, and I'm committed to doing both. Thank you.
All right, that was a wonderful presentation, Dr. Griffith.